Hi there, this is Sarah. I am currently in a specialty rotation at a renal disease and hypertension clinic, so this presentation is on a patient I saw last week. WB is a 56-year-old male who presented to the specialty clinic for a regular follow-up visit of his previously diagnosed stage 4 chronic kidney disease. He's also been diagnosed with hypertension and other diagnoses associated with chronic kidney disease, such as vitamin D deficiency, renal osteodystrophy, anemia, and hypervolemia. He had an AV fistula that was placed in his right upper extremity on February 1st of this year, but has not yet begun dialysis treatments. During this visit with WB, I reviewed his medications with him, completed a thorough review of systems and physical exam, pertaining to any uremic signs and symptoms that he has maybe experienced since his last visit in March of this year. Notable positives included complaints of increased edema, especially in his right upper extremity, that extended down into his wrist and hand, but was not limited to his joints, and had persisted over the past 5 months since the creation of his fistula. And was associated with difficulty using his hand due to the swelling. About 2 weeks ago, he began taking furosemide 40 milligrams daily as opposed to every other day or 3 times a week due to his increased edema. Pertinent negatives included unexpected weight changes, shortness of breath, cough, chest pain, palpitations, decrease in urine volume, any trouble with urination, dysuria, flank pain, frequency, urgency, or hematuria, dizziness, seizures, weakness, lightheadedness, confusion, sleep disturbances, or headaches. On physical exam, he had a normal range of motion with his right upper extremity and edema all throughout his arm that was +2. He had a positive bruit and thrill. However, the thrill was slightly difficult to palpate secondary to the edema. And the bruit was noted over the entire bicep. It extended laterally from the fistula. So differential diagnoses will be, leading diagnosis is a large draining vein, collateral vessels that are competing for blood supply from the access site, venous stenosis, or venous thrombosis. So bruit and thrill, as I said, were recognizable upon exam, and the bruit extended laterally from the AV fistula, which is suggestive of competing collateral vessels that are draining blood from that access site and could lead to thrombosis of the access site. With thrombosis of the access site being the diagnosis on physical exam, it would be a weak or absent pulse over the access site, which was not found on physical exam with WB. I found two articles. I focused on one, which was a level 6 of evidence. It was an article that summarizes the recommendations for ultrasound techniques used in assessing patients with permanent dialysis access who are experiencing acute arm swelling. What was most helpful from the article was the included discussion on differential diagnoses for patients with acute arm swelling and associated exam findings. It also included recommendations for further imaging or intervention after ultrasound evaluation. I also am going to include a link to the National Kidney Foundation. They have clinical practice guidelines that were published on their website in 2006, so pretty old. And since this is such a specialized case, it was hard to find relevant data out there for articles. However, the clinical practice guideline, which is level 7 of evidence, said that preferred surveillance techniques for fistulas would be duplex ultrasound, MRI angiography, or any direct flow measurement techniques. And these recommendations are certainly applicable in this specialty setting. However, in the primary care setting, these are certainly not decisions I will likely be making for patients who present with swelling of their arm with a present AV fistula or graft. The care that was given during this visit appears to be appropriate in comparison to the recommendations. The patient was referred appropriately to interventional radiology, and out of curiosity, I did check to see if his visit had already occurred and the results, but the appointment is in 3 days, so unfortunately, not yet. I can't see what the interventional radiology team decided to do in this case, but he was referred for venography of the right upper extremity in the AV fistula access site. I will definitely incorporate the information from this case into future encounters with patients by first off recognizing that it's so important to thoroughly do thorough physical exam on any dialysis access that my patients may have. Obviously, I won't be managing these patients with late-stage chronic kidney disease, but it's extremely relevant and a learning point from this case to know that decreased access flows and loss of patency lead to overall limited dialysis delivery and extended dialysis times, and thereby increases cost in patients' morbidity and mortality, not to mention decrease in their overall quality of life. Interprofessional care was not really a part of this visit other than referral. A medical assistant did complete vital signs and do an initial intake. 2 other learning points. A hypercoagulable state and hypotension are additional risk factors that could lead to acute thrombosis of an access site. And thrombosis of a fistula or graft is one of the most common causes of access dysfunction and can result in substantial acute arm swelling. And as I said before, a weak or absent pulse over the access site would be noted on exam. And 15 to 20% of hospitalizations of chronic kidney disease stage 5 patients are due to access complications. So it's a really important thing to know when seeing chronic kidney disease patients for other reasons in the primary care setting, just to realize the importance of their access and how it affects how their access and the health of their access site can affect their overall quality of life and obviously their health. So thank you for watching.